We have the slides now. My conflicts of interest are still the same. Well, we have very clear guidelines recommendation. 1 hour ago, we have been discussing that very much in detail. The foundational therapy is very much supported by this meta-analysis showing that whether we do combine the 4 pillars, we can achieve a 70% reduction in risk of cardiovascular mortality. This explains why all the worldwide guidelines do all recommend foundational therapy with class 1 recommendation. However, we do have evidence from real world data showing that even if there is such a strong recommendation in guidelines, this doesn't really is applied in our daily clinical practice. And here we have data from 3 large registries from Japan, Sweden, and US that we put together a few years ago, where you could see clearly that although there was class 1 recommendation for all these medications, the implementation was limited and it took time. So there were here illustrated 2 different aspects of clinical inertia, which is sometimes not initiating treatments, and even if we do initiate treatments, it takes too long time following diagnosis of heart failure or an heart failure hospitalization. At the same time, you also see that after 1 year, many patients discontinue treatment. So one problem is prescription, the other problem is actually keeping patients on medications. And more recently, we presented this at the ESC. We pulled together data again from Japan, Sweden, and the States, and we pulled 1.3 million patients newly diagnosed with comorbid heart failure and CKD. And you can see that after the diagnosis of these 2 conditions together, there was just like a slightly increase in use of GDMT, and actually following diagnosis, there was not much change over the follow-up. So this also clearly highlights that whether patients get diagnosed the disease or they get an hospitalization, that's a unique moment for fostering GDMT implementation, because later probably there will not be chance to do it once again. And again, on status of implementation, there are data from registry. This study was presented as late breaker during the Heart Failure Association meeting this year. You can see the status of uptake of GDMT in Italy here. It's 3,000 patients with heart failure. I highlighted patients with FRF in this slide. You can see there was overall good use of beta blockers, somehow more limited of MRA, ARNI, and RASI, and SGLT2 inhibitors. Well, when you look at these registries, you really always need to make some considerations. And if you look at these, now you see that implementation is not that bad. If you look at the previous slide, this one, you see that it was extremely bad. What is the difference? The difference is the study population. This is a registry which enrolled patients mainly from secondary and tertiary care. Patients are better treated. This study instead enrolled patients from electronic health record. So basically all patients with a code for the disease were included. So basically the truth is in the middle. There is still clinical inertia. There is still need of implementation. And this picture is very likely overestimating what we do in our clinical practice. In this slide, I really like one thing. You see in in dark blue, that there were patients who were not receiving medications, although they didn't have any contraindication. These are the patients where clinical inertia is, and you see that depending on the drugs, can achieve even 30% of the population in this selected cohort of patients from secondary tertiary care. Another interesting finding was that patients who were enrolled in the registry and then by protocol met again after 1 month, you could see that there was an improvement in GDMT. This clearly highlights that whether we have a clear and structured protocol for follow-up in our patients, this leads to implementation of GDMT, and also having registries actually helps very much to do so. Another similar study has been done in Norway. In Norway, Sweden, and Denmark, we have large nationwide registries on heart failure. And the Norwegians here showed that following 2021 guidelines recommendation, there was huge implementation of use of medications in their guidelines. Once again, this is a quality registry. Here, these people need to include patients in the registry overall to lead to an evaluation of the quality of care they provide. So you see an overestimation of what it is done. Probably in the general population with heart failure, the degree of implementation will be less. What is very interesting to see is that together with implementation of GDMT over time, there was also a reduction in cardiovascular mortality and heart failure hospitalizations, which highlights once again that even in real-world practice, implementation of GDMT works. And these are data from my group, again presented at the Heart Failure Congress 2025, where we showed a overall very good implementation of GDMT in Sweden. Look at RASI and beta blockers, almost all patients received them. You see that there was an improvement in MRA use over the time, and you see that in 2023, 60% of the population was on quadruple therapy, which is very good achievement in a registry setting. So these overestimate the use we do of GDMT, but it also tells you that whether we place patients in a setting which is similar to this one, we could get very good results. The Titrate HF has been another large registry to recently deliver results. It shows the implementation of GDMT in the Netherlands. You see that after the heart failure diagnosis, actually GDMT implementation level of after 2-3 months, so there was still room for implementing GDMT, which was not fully achieved. And another very interesting result was that in these patients at 6 months, in 60% of the cases, there was an improvement in EF. And this is an important result because we do refer for devices patients after they have achieved OMT, and therefore if we take time for optimizing GDMT, actually we delay implantation of devices, and this poses patients on risk of mortality, morbidity, because we might not be implanting immediately when it's needed, a CRT and a defibrillator. What are the barriers to the implementation of GDMT? And we asked that to 400 cardiologists in Europe with the HFA of the ESC, and we asked also what were the reasons, the barriers to the implementation of GDMT. In 70% it was hypotension according to cardiologists. In 50% of the cases it was a worsening renal function, 45% hyperkalemia, and 40% patient adherence. And if you look at the right side of this slide, you might see that there was an overreaction to whatever might be interpreted as potential side effect of the drug, as soon as potassium was slightly increasing, even in ranges where we can use safely medication, there was withdrawal of medications, which clearly highlights that sometimes fear for side effect is even more important than side effect per se. How should we improve GDMT in clinical practice? Well, these are some strategies you may consider. First of all, patient profiling. Patient profiling is important because you can use the different pharmacological properties of the drugs we use for FREF to try to tailor at the best medical treatments in these patients. By checking blood pressure, rhythm, heart rate, renal function, hyperkalemia, you can actually tailor the best treatment for your patients with medications, with FREF. So the first barrier to implementation of GDMT was hypotension. If we want to use the patient profiling approach, what medication should we prioritize? So first of all, in the emphasis trial, it was shown that MRA impact on blood pressure is limited at the doses that we use these medications in heart failure care. If blood pressure was low at the baseline, of course in the range that was allowed in the trial, this led over time, MRA use led over time to an increase in blood pressure. And this was due, of course, to the improvement of the pump function, which also led to the improvement in blood pressure. So this really tells you the use of MRA in this setting is safe. We know that SGLT2 inhibitors impact not really much blood pressure, and in particular whether blood pressure at the moment we prescribe medication is low. And we also know that whether optimizing use of beta blocker is challenging for achieving a heart rate target. Because of low blood pressure, actually we can use ivabradine, because this has a very limited impact on blood pressure. At the same time, it improves mortality, morbidity in patients with heart failure. So don't forget this medication when it comes to patients with lower blood pressure at the baseline. Of course, we are not talking about patients with symptomatic hypotension. In the Victoria trial, and therefore we are in the setting of worsening heart failure, the impact of vericiguat on blood pressure was overall limited, more accentuated in older patients. So this is another medication we could prioritize in patients who are slightly hypotensive and have a FREF and a worsening heart failure event. And we all know that sacubitril/valsartan reduces blood pressure, but it's also true, and we know this from trials, that whether we do a switch to ARNI once that ACE or ARB is up-titrated to target dose, actually the switch will not lead to further reduction in blood pressure as shown in the PARADIGM trial. So in patients with lower blood pressure, don't start directly with sacubitril/valsartan, but rather first up-titrate ACE or ARB. Then the second barrier to implementation was worsening renal function. So how we treat patients with CKD and heart failure. Well, in FREF, first of all, we should prioritize the common pillars for treating CKD and heart failure. So RASI and SGLT2 inhibitors are life-saving treatments for both these conditions, and therefore we should really prioritize. When it comes to ARNI have been shown to actually lead to a less decrease in eGFR over time as compared to ACE inhibitors. So whether patients have lower eGFR at baseline, probably we should prioritize the switch to ARNI over continuation of ACE. And patients with worsening heart failure, well, you can start vericiguat without any problem, since this doesn't impact renal function. Hyperkalemia was another barrier to the implementation. We know from the PARADIGM-HF trial that whether we switch from ACE to ARNI is associated with a less higher potassium levels as compared to ACE inhibitors, and they do even work, ARNI even works as enabler for MRA use. So definitely a treatment to optimize in this setting. SGLT2 inhibitors have been shown to lead to less likely discontinuation of MRA in clinical trials, and therefore to reduce the risk of hyperkalemia as well. So start SGLT2 inhibitors also in combination with an MRA could be a very good idea. And vericiguat doesn't impact at all potassium levels. So again, safe in the setting of worsening heart failure, even if potassium levels are slightly increased. Then another strategy for implementing GDMT is to use enablers. What are enablers? For example, K binders have been shown to be able to lead to better GDMT implementation in clinical trials. This was true in the Diamond trial for patiromer, patients randomized to patiromer as compared to placebo in the setting of a high risk of hyperkalemia, led to better implementation of MRA and of RASI in general, and to less hyperkalemic event. So these are enablers for the use of other medication, namely RASI and MRA. And the SJC in the Realize K trial, so another novel K binder, also led to better use of MRA, so more optimal use of of MRA in patients randomized to the treatment as compared to the placebo, although there was slightly increased risk of heart failure hospitalizations, but this was very limited in a small subset of patients who were probably congested when they got the treatment. So by using K-binder, the amount of fluid retention increased. And the role of novel K-binders is reported in guidelines and in this position paper that we published a few years ago, where we did suggest that whether potassium levels are over 5 and patients are not on GDMT, we should start a novel K-binders while up-titrating GDMT. Also, devices might work as an enabler for pharmacotherapy. This is a study from my group where we actually, in a registry setting, we showed that whether patients with an indication for CRT and not do receive a CRT, actually there would be chance later to better optimize GDMT. This is due to the fact that CRT leads to better blood pressure levels and better renal function due to the fact that pump function might improve, and therefore even if patients were hypotensive or with very low renal function at the baseline, after they get a CRT, there could be more room for implementing GDMT as well. So CRT to be considered also as an enabler, of course, in patients with an indication. Using accelerated GDMT implementation clinics is important. In this Team HF trial, it was shown that whether there was a multidisciplinary team of a pharmacist, nurse, and cardiologist working together in this kind of clinic over 3 months, there was a better achievement of GDMT and better use of doses of this medication. So once again, whether the follow-up is well structured, you will see that there is a much better improvement in prescription and use of medications. And in Team HF, it was shown that this will translate in lower symptoms for our patients, less NT-proBNP levels, a reduction, actually favorable remodeling as assessed at echocardiogram, and at the same time also an improvement in EF. You see whether we do use better GDMT, you get all these results all together also with an improvement in the degree of mitral regurgitation. So you clearly see that whether you structure well your follow-up and you have chance to improve GDMT in your patients, there is definitely an improvement in terms of many different outcomes and not only mortality, morbidity. Then if we want to implement GDMT and other strategies to use telephone-based medical therapy optimization, we do in Sweden all the time. It is also reported in this trial whether patients were assigned to telemonitoring. So a nurse was actually calling patients, and patients could measure blood pressure by themselves at home and take labs in a very pragmatic approach, together with the fact that we're able to check their heart rate by themselves and provide, of course, this information to the nurses. This kind of approach led to better use of GDMT and achievement of target doses as compared to usual care. Increasing physicians' and patients' awareness is important. Sometimes in the clinic we just forget that the patient may have an indication for a medication. So whether in our journal system we do have an alert system which tells you, well, you should prescribe this treatment in this patient because there is no contraindication. In this trial, it was shown that was leading to better implementation of GDMT as compared to usual care, as well as informing patients about best care they should receive before meeting a doctor was actually leading the patients to discuss with their physicians about the medication they should get, and therefore this was triggering physicians to prescribe medication as they should according to guidelines as reported in the EPIC-HF trial. And finally, patients with heart failure do not have only heart failure. As we showed in this study from the Swedish Heart Failure Registry, almost all patients have a very heavy comorbidity burden. and this leads to very much high use of medication, what we call polypharmacy, and polypharmacy in the guided trial was shown to lead to less use of GDMT. And in Sweden, in the Swedish Heart Failure Registry, we have been showing that patients are not really completely adherent to quadruple therapy, and whether they are not, this leads to increased risk of mortality, morbidity. And therefore, it's important to understand that we should prioritize GDMT, we should withdraw the medications which are not useful at a specific moment, or they are not necessarily in need of being prioritizing. Together with the HFA, we released a protocol for deprescribing, in particular also for deprescribing medications which are contraindicated, and as you see in our data are unfortunately still very often prescribed. Finally, you can use screening tool for identifying patients in need of implementation. If you have a registry, you can really find patients, identify patients who are not well implemented, and call them to your clinic and start implementation. This is what we do with the Swedish Heart Failure Registry in Sweden. So I have two main take-home messages. The first one is targeting physicians. So implementing GDMT, fighting against clinical inertia, is facilitated by adopting a patient profiling approach, by handling polypharmacy, by trying to increase physicians and patients' awareness for the importance of GDMT, and using screening tools for identifying patients in need of GDMT optimization and multidisciplinary work in terms of GDMT implementation together with new technological tools can really be key for implementation. And at the same time, we should not forget to target patients because adherence is still a problem, and polypharmacy as well. And therefore, developing strategies for targeting these two important problems at patient level remains key. Thank you very much for your attention.